Welcome everybody to the second Charm introductory webinar. Today we are joined by Divya from Delhi, Alan in Qatar, and hopefully Harry from Taiwan. And the idea was to start with Divya. So thanks for joining us, Divya. Looking forward to hearing the presentation.
Thank you very much, Jürgen, and thank you, Zoe, and everyone who's been working on this consortium and its initial activities. And thank you for the invitation to me to share my current work on health humanities and social sciences, and the terrain of concerns, interdisciplinary work that is distributed between medical humanities, health humanities, mental health humanities, new distinctions being explored in all these ways. I've been concerned with the way in which mental health is conceived, understood. Mental health policy is eventually shaped, and the problems of current policies, attempts at addressing the lacunae, are broached with respect to the societies of the Indian subcontinent, which are very old societies, highly mixed with an extremely complex histories of various peoples, their mixings, separations. And I echo from outside of the disciplines of psychology, since I'm not a practitioner of psychology, but I've been for a long time engaged with the tradition of philosophy, which has been concerned with the discourses of the psyche. And I refer here to certain strands of European philosophy, which themselves harken back to older discourses in many languages, of which only one example is of course, the ancient Greco-Asian, Mediterranean, North African discussions of the psyche or the soul, the very word that we now associate with Greek language. And I'm also very conscious of the fact that this term, psyche, Psyche, and the concern with it had in fact primarily been a part of philosophy. So it is from that perspective that I explore what are the discourses of the psyche in India, and how one could develop a better and more critical understanding, and eventually perhaps a more creative understanding of the psyche as the name of experiences, phenomena, affectivities, which are embedded in this deep, complex history, intricated history of the land that we call the subcontinent. And so I've been concerned with psychoanalysis, and I'd like to preface my remarks today by stating something which may be evident to many of us who perhaps engage in the same traditions of the discussions of psyche and of philosophy, namely that psychoanalysis does not enjoy prominence in the mental health landscape in most parts of the world. And at the same time, it does form a significant part of the health infrastructure, the mental health policies of certain countries. I think most prominent is France. The same is the case with other European countries, and to significant extents in the United Kingdom and the United States. And we also are aware of the numerous critical updations and modifications of psychoanalysis, in the sense that psychoanalysis itself is now the name of a diverse field, which is composed of several branches, different schools, perhaps appropriations and reinventions of psychoanalysis, much beyond what can be associated with Freud, who's considered in some senses to be the father, but we know what father means in and outside psychoanalysis. So that is the broad, complex field that I have in mind when I think of the concerns about society and psyche in India. And I would also like to add an important fact that may be less well known, which is that apart from this peculiar presence and peculiar significance that psychoanalysis enjoys in other parts of the world, with its various branches of its various associations, in the Indian subcontinent, it has had a very interesting and significant presence. Psychoanalysis was instituted in India formally in the very lifetime of Freud himself, and it is believed that the very first psychoanalytical association was instituted directly by Freud in Calcutta, in India, led by a doctor who then became a psychoanalyst called Girindra Shekhar Bose. But subsequently, while psychoanalysis has been more or less entirely absent from the mental health policy and the landscape of mental health clinics or institutions, it has enjoyed an extraordinary importance in the disciplines of humanities and social sciences. And their own epistemological investigations about their own histories and their relevance to India. And here, those who may be following these developments internationally as well as in India would be familiar with the works of course, first of all, Erik Erikson, who came and traveled to India and wrote a very, very important book on Mohandas Karamchand Gandhi. And in the next generation, Indian scholars like Ashish Nandi, who in fact calls himself a political psychologist, but his work is not confined to the discipline of psychology, but has informed very important developments in the Indian humanities and social sciences. And his work has been engaged with very intensely by psychoanalysts and scholars of social sciences in Europe, in France, for instance, in the UK, and in most parts of the world where post-colonial and then decolonial approaches to contemporary world history, to modern histories and societies have been significant. And works by Ashish Nandi, Sudhir Kakkar, and several other scholars. Homi Bhabha is another scholar that one should mention because he has engaged very closely with psychoanalysis, with Lacanian discourse, while trying to speak about or theorize modern Indian society and post-colonial society, concepts of nationhood, memory, trauma, and so on. So I'm very quickly referring to a range of very, very important and internationally significant scholars, all of whom have engaged with psychoanalysis. And therefore, I believe that an initial framework that should inform the kind of exploration I'm interested in is this presence absence of psychoanalysis, absence from the clinical landscape, but extraordinary importance in the social science and humanities and even philosophical discourse. And so why is it that psychoanalysis is used to generate, you could say, universalizing or globalizing statements about India, Indian history, and Indian society, and is seen as a powerful discourse to do so? And yet is not seen as of any relevance when it comes to dealing with the psyches of actual members of the subcontinental societies. In fact, at this level, the initial response remains that psychoanalysis is a Western, if not peculiarly Jewish Viennese discourse, and should not be or should be imported to other parts of the world only with extreme care. As we know, that statement itself has a history. It's not a new statement. And I think one of the most important thinkers who revealed this difficulty of the trans-cultural or cross-cultural relevance of psychoanalysis was none other than Frantz Fanon, who was himself a member of the colonizing and the colonized societies at the same time, and began his own theory of the psyche of the oppressed, of the wretched of the earth, of people with black skins, les peaux noires, with this understanding that the psyches, the subjectivities, and the personhoods produced in such important historical encounters like colonialism and racializing colonialism were bound to connect the psyches of the oppressor and the oppressed with each other and co-form them. And this is something that he demonstrated in his book, Peau Noire, Masque Blanc, Black Skin, White Masks, and also in Wretched of the Earth and other writings. So from the 1950s, when he was first writing, to now, 70 years later, what could be the resistances to psychoanalysis? And what could be the attractions of psychoanalysis that are exerted in these two different streams of Indian engagements with the question of the psyche, where psychoanalysis can be used to describe the history and the society, and especially to diagnose the colonial trauma, but is rejected in order to discuss the psychopathologies of the everyday life of Indians. And this is where the concern with philosophy on the one hand and psychoanalysis with the other hand requires us, or makes it incumbent upon us, to describe our own society. And when I say our, I mean this my society as a member of the subcontinent, as a denizen and a citizen of this region, my society. And so my current work starts with an acknowledgement that psychoanalysis could become or could serve as an interesting and revealing probe, whether it or not it is a valid theory, a universalizable theory, or a provincializable theory, I think is a subsequent question. But the first question is that we are dealing with the history of our own social science discourses and of our mental health landscape, in which psychoanalysis has always already been present, but in a peculiarly averted way, in a segregated way, if you like. And I would like to investigate the character of this segregation further. And I do use this word segregation quite consciously, as I will hope to indicate in the limited time that we have. So psychoanalysis itself is something that should be diagnosed with respect to the way it is present here. And it could at least provide us initial concepts to diagnose its own peculiar presence and absence, and also to diagnose the ways in which the extant social sciences in and about India, including outside India, have characterized Indian society. So what has been the characterization of Indian society in the pages of what psychoanalysts or social psychologists have written about India, and what aspects of Indian society remain hidden, if you like, unconscious in this discourse. So we can start by, again, re-emphasizing two aspects of psychoanalysis. One, that it implies a theory of civilization, and second, that it implies a theory of the clinic and of the psyche in the clinic. And the theory of civilization and the theory of the clinic correspond to each other. In other words, according to civilizational criteria formulated or grasped by psychoanalytical theory, the psychic fitness of the individual and the techniques of the restoration of his or her psychic fitness are determined by the theory. In other words, if there is a méconnaissance of the civilization, or if there is a certain shaping of the criteria of civilization by the powers that are dominant in that part of the world, the clinic itself will predetermine what should be the health and therefore the sickness of the individual, and depending on that, the techniques of the restoration of health. And it was in recognition of this correspondence between the theory of civilization and theory of clinic in psychoanalysis and in psychiatry and psychology in general that Frantz Fanon said in Wretched of the Earth, and I would like to quote these words. We have since 1954 in various scientific works drawn the attention of both French and international psychiatrists to the difficulties that arise when seeking to cure in quotation marks, to cure a native properly. That is to say, when seeking to make him thoroughly a part of a social background of the colonial type. And he goes on to say that clinics which are shaped in this way by the assumption that the oppressed, the colonized Black man must be restored to the social background of a colonial situation, is a man who will be made more ill by the clinic rather than restored to health by the clinic, because the clinic assumes that the civilization to which this Black person has to be sent back with health is a world in which the Black man must remain colonized. And if that is the division that characterizes a colonial society and a colonial situation, we should immediately be able to see that the Indian societies, which are determined very, very deeply and in very long-standing ways by the inequality of caste, are going to be structured by the same problem. In other words, perhaps there is a lack of attention to the psyche of all Indians, both in psychological theories and in the theories of the clinic, theories of mental health, therefore, because there is a certain section of Indian society whose health is presumed to be the fitness to go back and be oppressed within the system of caste. Unlike in the case of Fanon and this infrastructure that he was grappling with, we don't find sufficient evidence or any evidence, and we do have a suspicion that most parts of our population who are called and treated as, deemed as lower caste, do not enter the clinics. They also don't form part of the subjects who are studied and theorized in the disciplines of psychology. And as an outsider to these disciplines, I would like to quickly refer to some scholars who are themselves Dalit, that is to say, belonging to the ex-untouchable groups, but also including groups who may not be formally acknowledged to be untouchables, but have experienced exactly the same kind of treatment. And broadly, we could use the term lower caste or Dalit to refer to these very vast populations. We know from various different socioeconomic studies and indicators that this group of the oppressed of the caste system form more than 90% of the Indian population. And the groups who enjoy the privileges, who are the elites and who populate the very spaces where the theory of Indian society is produced and where theories of psychology and of the clinic are produced, these groups are the upper castes, who can be estimated to be less than 10% of the Indian population. I say that these are estimates because due to various state policies that are themselves governed and guided by the elite groups and the privileged castes, we do not have yet a current socio-economic caste census. So we don't have authoritative figures which everyone could acknowledge and accept. The last such census was performed by the colonial administration in 1931, and subsequently smaller censuses which do not manifestly acknowledge the status of caste have provided us the data from which these estimates are derived. More recently, due to the increasing political mobilizations and demands of the lower caste groups and their political representatives, socioeconomic caste-based census was collected in 2011, but its data has not been made public. And more recently, one of the states where this demand was raised again very strongly, namely the state of Bihar, conducted its own census. This was challenged legally, and we now have the data, and that data confirms what we could expect to be the pattern throughout the subcontinent. So once we know that we are now going to listen to expert comments by two psychologists, one a psychiatrist and another a social psychologist, who hail from the oppressed sections of society, we would be able to appreciate the nature of the lacuna, the grand lacuna in mental health discourse in and about India that we are confronted with. So the first is the remark by the psychiatrist and academic Sushruth Jadhav, who is based in the UK, and who has described himself as a rare voice who keeps posing the question of the absence of attention to caste in Indian psychology. And he's a senior psychiatrist and a senior academic who is therefore testifying to the continuing inattention despite the questions he has posed. So his questions are important for us today. And I quote, "How does caste shape individual psyches and determine collective mentalities? How and why does casteism, which we can understand as very similar to racism, because both of them are descent-based structures of inequality, which force certain groups to inherit the stigma and the obligations and sufferings that come with graded inequality. So how does casteism impact upon the inner lives of both the perpetrators and their victims? How can their psychological wounds be healed? How is caste-related victimhood constructed, experienced, and contested?" And here I'd like to just add a parenthetical remark, which I elaborate as I go further in my inquiry, that we are inheritors not only of this descent-based racializing system of caste in India, but we as a whole society, as a subcontinent, are also inheritors of at least 150 years of anti-caste thought, mobilization, politics, writing, art, much of which is not adequately translated, is not adequately studied and taught in our university syllabi. The same syllabi who are so committed to decolonial thought and decolonial program have managed successfully for 150 years at least to suppress the fact of caste and to prevent, if not postpone, a reckoning with the perhaps the oldest system of racism in the world. Much older, certainly, than the colonial racisms introduced by Europeans in various parts of the world. And so I'd like to continue. How is caste-related victimhood constructed, experienced, and contested through a cultural psychological language? How is it psychologically constructed and managed, both individually and collectively, which would mean both in the way that the clinic would anticipate and in the way that a theory of civilization should have anticipated? And he continues, what might be the cultural pathologies of the psyches of the perpetrators of casteism? Finally, to what extent does casteism and racism overlap or differ in their psychological antecedents and consequences? Some of you will know, and I will not elaborate on this occasion, perhaps for a later conversation, how long the history of comparisons between caste and race has been, both in India for 150 years in textual form and in the United States, and also in other parts of the world. And so I go on to the second remark by another colleague who is a social psychologist, not a psychiatrist. This is Professor Yashpal Jogdand, who is one of the very first theoreticians of the psychology of caste. And his forthcoming publications, I can share them. They will be available within a month, and some are already available. So I quote, Indian psychologists have demanded decolonization of psychological sciences, but have not made much effort to address the internal colonialism. And I think here internal colonialism is a strange and provisional metaphor, because we are referring to a very recent history of European colonization to talk about a very old and long-standing character of the Indian subcontinent. So to address internal colonialism, which Dalits, lower castes, experience in Indian society, the psychological thought of chiefly mainstream Hindu texts and thinkers, and I would like to add here that the ones he will name these are all not just Hindu texts and thinkers, but upper caste texts and thinkers, which are very well known internationally, again for 150 years. Thinkers such as Patanjali, who is associated with yoga, which today is offered as a panacea for well-being, wellness, mental health. Gandhi, I don't think that needs an introduction. Aurobindo and others have been studied and have been taught in Indian universities. Anti-caste perspectives and radical anti-caste thinkers such as B.R. Ambedkar, who is also due to very important twists in modern Indian history, became the chairman of the drafting committee of the Indian Constitution, and therefore is often popularly referred to as the father of the Indian Constitution. So you have Gandhi as the father of the nation and the father of non-violence in the whole world. And you have Ambedkar, who is considered to be the father of the modern Indian Constitution, which gave to us liberty, equality, and fraternity and civil rights, much like Dr. Martin Luther King. But the works of Ambedkar have been relegated to non-scientific spheres. They are often treated as political spheres merely for the demands of the lower castes. And hence, Dr. Jogdand observes that as a result, psychology in India and elsewhere has remained caste blind. And I would like to give a lot of weight and gravity to this word caste blind. So if health humanities is to be a discourse developed under the new imperatives to alleviate the inequalities in society by, first of all, recognizing them, and therefore bringing together the knowledge from social sciences to the disciplines of health, rather than leave health up to mere medicalization, then health humanities is perhaps the only name for the formal acknowledgement that social sciences must inform the medical discourses and vice versa. And in the case of mental health humanities, or mental health as a part of the obligation of health humanities, the social sciences, the disciplines of psychology and psychoanalysis, and mental health policy must be made to reciprocally interrogate and inform each other. And here we are, therefore, confronted with the stunning, but to me, absolutely not surprising fact that caste has been absent from the disciplines of psychology in India and abroad. Caste has been absent in the mental health policies and infrastructures of India and elsewhere, but caste has also been absent from the social sciences in and about India. And it has been absent in a peculiar way that, of course, caste is one of the important parts of the disciplines of sociology and anthropology, with internationally significant scholars like Louis Dumont producing the most important, at least earlier most important, but completely misguided and misleading textbooks on the caste system. And therefore, we should add another layer. Just as psychoanalysis is present and absent in the discourses in India and about India, caste itself is present and absent. It is present in the way in which the upper castes would like to discuss caste. This is nothing new. This is not modern. In fact, the best known texts produced by upper castes in the entire history of the subcontinent, and I think one would think of the Vedas as the first such texts produced by the upper castes about their own culture. That's very old and long-standing. And even the most recent social science knowledge produced about caste is mostly by upper castes and therefore registers their perspective. This can be understood by non-Indians as an exact parallel of the European or the white colonizers continuing to produce the first and last knowledge about the colonized. This stopped being acceptable anywhere in the world many, many decades ago. But it continues to be the case. The parallel continues to be the case regarding caste in India. So when I say, therefore, that caste is present, it is present in the way that is determined and acceptable to the upper castes, to the oppressor. But when I say that it is absent, it means that caste has not been described in the social sciences, let alone in psychology or psychoanalysis, in terms of the lived experience of the oppressed, the immediate and mediate knowledge of caste as registered by the ones upon whom this structure of graded inequality is perpetrated. And therefore, when we revisit the works of the few social scientists that I mentioned at the beginning, who have been known to produce decolonizing psychology for India, we find that the Indian psyche portrayed in their works is, in fact, the universalization of the upper caste psyche. So there is a discourse of the Indian psyche, but in fact, it's not the Indian, but the upper caste psyche. I've noted the reminder about time. So I would like to make just a couple of statements about where these prefatory cautions and recognitions that I've laid out today lead me with respect to some explorations with actual concepts from psychoanalysis. And the two remarks have to do with the real caste-based psychic experiences and formations on the one hand of the upper castes and on the other hand of the lower castes. And psychoanalytically, I address them through two means that psychoanalysis affords, even as I continue the Fanonian critique of psychoanalysis, where sociogeny has not been adequately discussed. And I think the sociogeny of caste and caste-based mental suffering should also be explored through a theory of sociogeny, like Fanon suggested. So the two methods or concepts that I explore through psychoanalysis are Verneinung, that is to say negation or denial, as Freud had theorized from 1925 onwards, and in many writings. This was taken up later by Lacan and by other scholars as well. In other words, why do the upper castes continue to structure the knowledge about India and about caste through the mode of a denial of caste as oppression? In other words, this denial, which we call caste blindness, is itself a symptom. And the second part is what I call the psychomachia. It's an old word known from Homer, the war in the soul. And psychomachia, or a conflict in the soul, is experienced by modern lower caste Indians, because on the one hand, they have a discourse of modern India as a democracy with equal civil rights and democratic political rights, and a disregard for caste, race, class, and gender, as expressed in our constitution. But the social imperative of a modern constitution fathered by the great anti-caste thinker Ambedkar is at complete odds with the everyday reality where caste inequality continues. I define this further in terms of two father functions, which, as some of you would know, stand not for actual fathers or for fathers at all, but they stand for the two social imperatives in India, which are at war with each other. And this war is experienced in the soul of every lower caste person. Its symptoms range from trauma, depression, which is often now being expressed and hopefully studied, but most visibly suicides in the modern educational campuses, including my own. The largest number of student suicides are suicides by lower caste people. In other words, very much the kind of melancholia that Freud had initially diagnosed in his text, Mourning and Melancholia, could be used to explore this self-denigration to the point of self-killing, which comes because our society gives two competing instructions to the lower caste person, that she should imagine herself as a modern citizen, but she should continue to obey the laws of caste. And so I thank you for your attention and look forward to discussing the details of this research on other occasions.
Many thanks, Divya. It's really wonderful, wonderful presentation, very rich. And I really hope we can find a means with the group to assist you in developing these ideas. It also, I think your ideas also call for a comparative analysis of sorts from our different perspectives. Just one immediate thought when you were talking about let's say, the presence of psychoanalysis as an academic discipline and the absence as in the clinical context. My immediate intuition, but I would need to look into this further, is that in Flanders in Belgium, it's the other way around, in the sense that psychoanalysis as an academic idea is very much under pressure, at least in my university,
Okay.
for reasons that I find incomprehensible, to be honest. But we'll need to discuss this further, I think. I'm afraid we
Okay.
don't have time for many responses or questions, but I'm sure that we'll find ways, hopefully also in September in Ghent, to continue the conversation again on this very rich. Do we have immediate brief questions? If so, that is possible, but I'm looking at the time, and it's already a quarter to 11 here. So I'm afraid we'll have to continue and move to the second presentation. Zoe, are you going to take over the introduction for the second
Yeah.
presentation?
Thank you very much, Divya, also for my part. Yeah, we move forward to the second speaker. I don't know who wants to go first, Alan or Harry. We thought of introducing Harry first, but I don't know if you would like to use a PowerPoint.
Yeah, I'm using PowerPoint.
So then I'm just very briefly going to introduce you as a historian of medicine who is working now in the Department of Medical Humanities and Social Medicine at National Cheng University. That is Taiwan, if I'm not mistaken. So
yes,
the floor is yours.
Okay, thank you. Now the computer asked me to set the security and privacy, and in order to share my screen. So I'm still trying it.
Or otherwise, yeah.
I had the same issue, Harry. I think I had to actually close out and then come back in to make those changes. So you may have to leave the main.
I have to leave it. Okay, sure. Okay, so bear me 1 minute.
Or maybe, yeah. You could also send it to me, but maybe we could, yeah. Now it's a bit awkward to move forward. So are we going to wait for Harry? I don't know. I don't hear you, Jurgen.
Sorry, I was saying maybe we can have Alan first and then.
Then yeah, I was also thinking.
Yeah.
But hopefully Harry isn't mad then when he is.
Okay. Well, hopefully he will come back.
But go ahead, Alan. There he is. Okay.
Okay, good.
Maybe he's faster than we thought. And do you know where the share button is, Harry?
Yes, I do.
Okay.
And still.
Doesn't work. You can also send me the file. Just send me the files, and we can first, or Alan can first go start with his presentation. Then I can share your slides.
Okay,
instead.
sure.
So
I will do that.
So we move to Qatar then. Hi, Alan.
Okay.
Now hopefully this will work. Let's see. Presenting. Do you see my screen, or I hit the share button?
I see the okay. No.
Screen. And oops.
I see the screen, but you shared our yeah, now we see your slides.
Okay. Now is this full screen now? Are you seeing full screen?
Yep. Very good.
Thank you all. I'll try to, I think we're, our time is, I think we're finishing up in about 45 minutes. So I'll try to keep this brief, 15 minutes. So thank you for inviting me to this charm group. And I have a lot of interesting questions for Divya. And there's a lot of actually overlap with her work and my work. And very similar things are actually happening in the intellectual life in Qatar. My colleagues in the psychology departments are examining the same issue of the universality of psychology and psyche and the soul. And there's actually a large conference going on soon about that. There's been initiatives to develop an Islamic psychology. If we look at and also in medical ethics, we have the Center for Islamic Legislation and Ethics. They've been really questioning this idea of the Western focus on international medical ethics, based really one of the standard models is it's called 4 Principles, which is developed in the United States. But that's really been questioned as far as whether medical ethics and bioethics are actually universal. So there's a lot of interesting work going on here, which I think parallels Divya's work in India. So this is my disclosure statement required by my university. I won't be talking about any medical products or drugs, medical drugs, since I am at a medical college, and my college is Weill Cornell Medicine-Qatar. We're a campus, a satellite campus of Cornell University in the United States. Our medical school is in New York City, and we confer the United States MD, the medical degree, to students in Qatar in the Middle East. I've been working here for about 18 years, transferred from the main campus, and I am in the pre-medical department, and I teach humanities courses in the pre-medical department. I also do teach in the medical school as well, teach narrative medicine in the medical school. And just briefly, my background. I started out at the State University of New York, then moved to my 2 previous appointments were at Cornell University and the Pennsylvania State University. Then I moved back to Cornell University on the main campus. I was teaching there for a number of years, and then I was recruited for our new medical school in the Middle East. And this has been my longest position so far, arriving in Qatar in 2006. So again, I've been here about 17, 18 years. Just some of the courses I've been teaching, if you'll notice the topics, a lot of general humanities courses, which are overviews of the medical humanities, giving students insight into all of the different kinds of medical humanities that are going on. This includes art therapy, music therapy, expressive arts therapies, but also sociology of medicine, philosophy of medicine, and history of medicine. I would characterize my work primarily as a historian and sociologist of medicine, and also do publish in the philosophy of medicine. Been very interested in that and the overlap between religion and medicine. And my original training was actually in Shakespeare, it was in literature, but my PhD thesis was a cross-disciplinary PhD thesis on Shakespeare's knowledge of astrology and astronomy. So I became very familiar with the history of science and the history of medicine literature. And then when I moved to the medical school, I basically shifted my research focuses away from purely literary discourse and literary studies, more towards the intersection of literature and medicine, narrative medicine, literature and medicine, and as I mentioned, sociology and history of medicine. So these are some of the recent courses I've been teaching, and I've also been very involved with the ACCME. This is the Continuing Medical Education Council for the United States. So I also do workshops for clinical physicians, so physicians who are working in hospitals, educating them about the practical dimensions of medical humanities in their work. And that includes communication skills as well. So I'm very interested in not only a theoretical basis for health and medical humanities, but also I'm very interested in their clinical application. How can we actually use this? Because that's where the grant money comes from to do my research. And I am in a medical school, so I'm constantly trying to defend myself as opposed with respect to how does my work actually fit into the medical program. We are a very biomedically focused institution. So on the main campus, a lot of the research is actually into drug therapy, pharmaceuticals. Our previous dean was the really one of the founders of the developed the drug Lipitor and those class of statin drugs. So we're very closely allied to the pharmaceutical industry and clinical trials, drug trials, and also cancer therapies as well. So I'm a bit of an oddity in my institution, and there's 4 of us here who teach humanism, and we are constantly trying to justify what we add, what value is added by our presence and our courses. So just a brief review of some of the, I do a lot of, as I mentioned, I do work with clinicians to educate them about the medical humanities and the potential use of the medical humanities in their clinics. And I also do a lot of outreach in the state of Qatar. Here where I am in Doha, and some projects that we've done as far as outreach are, well, actually, this was more inter-campus work, inter-campus research. We're very interested in how this was a research involving medical students and art students at our local art college. We were interested in problem solving. How do these different groups approach problems and how do they solve them? So we got them together into a course. We asked them to solve a problem, which was create a piece of art, which would have a tell us something about medicine, about the social, cultural dimensions of medicine. And we observed and we tested them with various psychometric tests about their creativity and problem-solving abilities. And so this picture you see here is very interesting. This is MRI. This is the MRI of a student's skull, who they and then they put it on a laser printer, laser cutter, and cut out thin sections of their skull and then reassembled it. So another outreach project. So with my medical students, we went to the Qatar Cancer Society, went to the local cancer society, and we, in conjunction with the patients there, we captured the stories of persons living with cancer, and we wrote up their stories and translated them. This is Arabic, Qasat Amal. There's an Arabic version, an English version, and this is used in patient education groups throughout Qatar. So again, this is an example of the clinical dimension of the medical humanities, where we were able to use what's called peer-to-peer patient education, where patients themselves can explain their sort of non-clinical, what happens to me outside the clinic. What is my life like? How do I talk to my children? What do I do as far as working? How do I manage cancer in my daily life? So this is probably one of the most important projects of my entire career, in that there's a very strong stigma in this region about talking about cancer. People do not talk about cancer here. There are various explanations. It's probably a folk belief in talking about bad things. If you talk about bad things happen. So there's a very strong taboo. In fact, they will not even say the Arabic word for cancer is al-saratan. They will not even say the word. It causes such fear in people. So they call it things like al-khabith, meaning the malicious thing, that terrible thing, or that disease. So this was a very important milestone, I think, in my career, where I was able to, with my medical students and my colleagues, we were able to open up a discourse about cancer and talking about cancer, that it's not taboo. So I'm very proud of this and proud of what my students achieved with this project. Another outreach project we did with the art school, I work very closely with our School of Arts here, we did an arts and health program. This was with Down syndrome children. And there are not a lot of opportunities in Qatar for Down syndrome children. They're not integrated into the workforce, and they face a lot of discrimination. So we basically developed an art program with art therapists, and we got the children to create art. And the goals of the program were to instill self-confidence, give them a skill set, and basically something to do, because again, they're, as adults, both children and adults, they're not mainstreamed into the regular classrooms. And there's really not a lot for them to do as far as activities. So that was a very successful project with the art school. Here's some of the art that the students produced from this project. So we explored themes. The art therapists in this project, they explored themes with the children of identity, belonging, self-worth, and even self-care. And also art therapy is very good for fine and gross motor skills. So even just holding a brush or holding a pen for some people is very challenging. So arts therapy and many expressive arts therapies actually have a component of physiotherapy within them, actually getting people to move around, getting them some exercise. And a lot of these expressive art therapies are done in groups. So we get the benefits of socialization, where children or adults who are isolated, and facing those challenges can get into a group and do something with a group. And there are obviously therapeutic benefits simply with being with a group of other people. I'm doing a clinical trial right now with my art therapy colleagues. It's a telehealth. We've collected all the data. We're writing up the results. So this is basically telehealth online therapy for children with depression, anxiety in Qatar. And as I say, we are trying to do proof of concept to find out if this kind of therapy services are effective. So the preliminary data indicates that yes, it does work. This is very challenging because Qatar does not have any rules about telehealth or any laws about it. So it was very hard to get ethical approval for doing research on human subjects because it was a very new, very novel research for this region. This is probably the first clinical trial of telehealth, possibly in the entire Middle East, certainly for this region. So it was very difficult to get approval to do this because it was just too new. I've also been involved in educational efforts with international conferences. I was the lead organizer for our health communications conference in the Middle East. That was very important. Many hundreds of people showed up for this conference, and what we found is that teaching health communications is not a standard practice in the Middle East, in the MENA region, Middle East, North Africa region. A lot of countries, it's simply not part of their medical education system. They're expected to learn on the job. So there was a lot of networking going on and trying to get programs and training to different parts of the world, such as Yemen, Iraq. These countries are just beginning to incorporate healthcare communications into their medical systems. In the past, it's just some of the developing nations are really focused on healthcare capacity, basically just getting enough qualified doctors out there because of doctor shortages. Communications is seen as something that you could just learn on the job. It's not something that they want to really incorporate into the medical education systems, but this is changing, and our university our medical college is in the forefront of promoting healthcare communications as a standard physician competency. And I've also organized two medical humanities conferences for the Middle East region. Let's see here. That's Arthur Frank. So if you know Arthur Frank, he's a very famous sociologist in medicine and narrative medicine person. He was our keynote speaker. And as you may know his work, he himself suffered from cancer. And so he has written extensively about the literature behind cancer narratives. He gave again, this was very moving for me. So I organized a talk for Arthur Frank at our National Convention Center. I would say there was at least 3,000 people there. And again, getting back to the idea that cancer is not something that's part of public discourse in this country. And after the talk, people came up to him and they were in tears, and he was really mobbed after the talk, and people were thanking him and shaking his hand. And they were basically all saying, thank you for talking about this. And nobody talks about this. When people have cancer, we don't talk about it. We just don't. So again, he opened up really a lot of avenues for people to seek medical care, preventive care, acknowledge that cancer is a disease and has to be dealt with instead of this really fear, this taboo against even talking or discussing cancer. In the stories that we collected for the Qatar Cancer Society, many persons with cancer did not tell their families, especially children or elders. So that's the extent of the taboo that I was mentioning. And so we've had actually two conferences on medical humanities here. We've published the proceedings of these, and these are basically extended abstracts. So this year we are planning for 2025, we're planning the third version of this conference, and everyone of course is welcome. So what we've done, we've extended, instead of having a narrow regional focus, what we're doing is we've rebranded this conference to include global perspectives. So basically what we would like to do is invite the entire international community who are involved in health and medical humanities to come to Doha. This will be an in-person. There will be a hybrid version, an online version as well. And to basically exchange best practices. This is really a new idea and an emerging field, the health and medical humanities in this region. It's not something that was really thought about until, I would say, the last decade. And I would say our university is probably the leader in this field at this point. So look for a call for papers shortly. I'll send it, of course, to the CHARM network. And that will be in February 2020, 2025. I'm getting the budget approved right now, but it should be approved and we'll send out a call for papers. And again, we're very interested in the global perspective on this topic. And some of the questions, of course, that are coming up are the medical and health humanities really were developed as a Western construct and as a field in the West. And just as Divya was talking about psychology and the universality of some of these concepts, this is what we'd like to question is, how do we translate some of the ideas in medical and health humanities to different cultures, different religions, different ways of thinking, and also different medical systems, which are structured differently than they are in the Middle East. Some of my early work, getting back to my, I'm sorry, this is a little bit out of chronological order, but some of my early work was in, again, history of medicine, and that's probably my main field where I have the most publications is the history of medicine. I was able to discover some texts from the Renaissance, which had women writers. So women actually writing about medicine, and this was a very overlooked topic at the time. I consequently published those texts. So I went around the libraries around the world and I found more texts of this nature. These were basically what are called almanacs, which are very popular types of writing, but there were some women who wrote almanacs and wrote medical advice for women in these. So this is one of the major, I'd say, discoveries of my career when I was doing more literary type work. But as you notice, these were medical texts. So this was my interdisciplinary interest from the beginning of my career, was the overlap between medicine and literature and narrative medicine. I also have edited a popular textbook. This is used a lot in 19th century classes who study 19th century literature or the history of 19th century science. It's basically an anthology of original texts, which I edited. Darwin and Goethe, Dalton, you recognize all these names from the history of science. And I had done work as a historian of medicine. I've been very interested in the history of psychology and psychiatry, particularly in the Middle East. And I was invited to this volume by my colleague, Lassie Gamelgard, and on madness in literature. And what I did is I looked at a classical work called Layla and Majnun. And it's very interesting because it's really a textbook of conception of madness in Islamic psychology. So he almost went through all of the different viewpoints on what madness and mental illness are. And it's actually was studied, interestingly enough, it was studied by other Islamic scholars, almost as a sort of a checklist or, again, encyclopedia of what are the different ways that we look at madness. There's the very common, and this is very common today, and this is why it's important for me to study the history of medicine in the Islamic context, and also the history of religion and psychology, is that many of these attitudes, traditional attitudes, are still around today. So, and they do impact clinical care. For example, the main idea about mental illness in this region, the Gulf region, is that it's caused by spirit possession, which are called jinn or genies, which are in the Quran. And it's a widespread belief that if you are experiencing abnormal behavior, that you are possessed by genies or jinn. Almost 50, a recent study showed that almost 50% of people believe that mental illness is caused by spirit possession. So this has huge implications for clinical psychiatric care, which means basically a lot of people will not go to a Western psychiatric clinic, which we have here. We have a Western-based allopathic medicine psychiatric clinic in Qatar, but people will not go to it. They don't believe in the model of psychology and psychiatry that's been developed in the West. And I think this is very similar to what Divya was saying in India as well. It's seen as a Western model of mental illness. This is a very important article, which I basically summarized all of my work in Qatar, where I was trying to show the clinical dimensions of the history of medicine, how actually we could use it in a very practical way in the clinic. Some of those ideas were, again, understanding patients, so understanding the patient perspective of disease, when patients hold historical ideas, traditional ideas about their own illness. So that's sociology of medicine, philosophy of medicine. There are many, many works that show conflict between the provider and the patient when they don't agree on things like, do bacteria exist? Do viruses exist? What is the cause of mental illness? Is it organic brain chemistry, or is it spirit possession? So this has very important impacts on the clinical experience. But there are many, many other ways. Cultural competence, so you can learn cultural competence through history of medicine, et cetera, et cetera. I won't go through all of the ideas that in this paper, and again, I've been publishing a lot on Islamic history of particularly Ibn Sina, one of the great Islamic polymaths. He was a very interesting person. I've also, in my article, suggested that, and this has been suggested in books and articles about professionalization, that this hero model or setting up mentors is actually a positive thing for medical professionals. If they can identify someone they look up to, someone that they want to emulate, then that should be promoted in medical education. And this is somebody that, students from this part of the world every student knows who Ibn Sina is. Avicenna in his Latin name, Avicenna or Ibn Sina. They all know who he is. And he was a very amazing thinker. Some of the things that can be emulated, he was a very close clinical observer of nature, which is very important for diagnostics, to observe symptoms and signs of patients. It was very close clinical. He was basically a rationalist. He was an Aristotelian. So he downplayed the religious dimensions of medicine and basically thought that diseases are malfunctions of the body. So he is a proponent of modern evidence-based medicine. So there's a lot of things. And also he was very prolific and very interested in new knowledge as an experimentalist. So there's a lot of things that he could be set up really as sort of a mentor for someone to emulate in professionalization. I've also been writing on bioethics, Islamic bioethics, and diverse topics such as stem cell research in Islam. And I looked at the different religious views on using stem cells. And that's about it. I think I'll stop there. Yeah, I hope I haven't gone too long.
No, thank you very much, Alan. It's very impressive what you have done so far already, and I'm looking forward to discussing more of these cross-cultural data you have gathered also on these Islamic views on. You now said talking or not talking about cancer, but also on the predestination and belief you wanted to share with us during our summer school in Ghent. So I think it will be And we're really looking forward to discussing all these things with you. I don't know whether there are any quick questions for now. Seeing that you are at crossroads in the world and are combining a lot of cultural insights, so maybe someone would like to. But I see Jurgen.
Well, no, just I was of course I was attentive all the time, but especially when you were talking about the Doha conference, and maybe if it were an idea, we can discuss this later to have a sort of a charm panel or something on it, so that we can be there also as a group. That would be wonderful. A wonderful opportunity as far as I'm concerned. But of course, that's something that we can discuss later.
That sounds like a perfect idea. Yeah, let's explore that at some point, and we'll definitely have a student panel. I want to get student perspectives on their clinical experience with the medical humanities. I think this is going to be really a teaching conference where I think where medical humanities are more developed, that a lot of the people from this region will want to go to workshop type events to find out, what exactly does it mean and how does it translate into what I'm doing in my medical school or in my university.
Okay. Maybe we should move forward now to Harry. I've received your slides in the meantime, so I'm going to share my screen.
Okay. Thanks a lot.
Okay, so go ahead. And thank you very much, Alan, for your presentation.
Right. Okay. Thank you, first of all, for Zoe and Jürgen for inviting me to this exciting panel. And sorry I came in late because I got the time zone wrong. But I hope that I didn't miss much. Briefly, using my 15 minutes to introduce to you what I've been doing for the past 10 years. Right. Oops.
Oh,
okay.
Normally,
yeah,
it works now?
Yeah, it does. Okay, perfect. Yeah, so I think my job is quite relevant to both Divya and Alan's. My first research in medical history is also about universality, right? I'll briefly talk about it later. And this is a bit of myself. I was trained medically before and practiced very briefly before delving into the history studies, right? And so for the past 10 years, I've been teaching and developing medical humanities curriculum in different medical schools, basically most of them in Asia, in Hong Kong, in Singapore, and now I'm in Taiwan. And next slide. Okay. Oops. Yeah, forward. Yeah. So this is the book I previously published in 2021. And this is about a story of universality. And I looked at how physicians and scientists, the World Health Organization in the 1940s and through to 1960s, how they managed to create the universal language of psychiatry, basically the international diagnostics diagnosis for mental disorders. And so this was based on then very popular scientific internationalism and highly impacted by then belief in technology, mostly computing technology, statistics, etc. But unfortunately, that they kind of eliminated quite a few cultural elements. And so that actually they successfully rewrote the chapter 5 of ICD, nowadays still in use. But I'm still commenting on the challenges and the limitation of that kind of universality. So this is quite relevant to our previous presentation. And I have other medical history projects right now. For example, one of them is writing about the story of lunatics in Hong Kong. And what interesting about this story is that they are not patients who are confined in mental institutions, right? Because of the colonial setting and also the environmental, the context of Hong Kong, that a lot of patients, they were actually, this is the politics of repatriation. A lot of them are drifting in the ocean, right? So hopefully I'll complete the writing in 1 year. And then I have another project that is looking at the history of health diplomacy, through, I think this is also very relevant to Alan's call for paper, because I'm looking at the relationship between Saudi Arabia and Taiwan in the 1970s, right? And so there were underneath the humanitarianism, I'm looking at the informal life politics of these participants, including doctors and other paramedics staff, right? Yeah, so, and on top of that, I'm currently a co-editor of Social History of Medicine. So we welcome different approaches across different cultures, right? And next slide. Yeah, so for the past few years, I've been trying to develop medical humanities syllabus in medical schools. And I found there are a few challenges, right? So it is very difficult to find consensus between humanities scholars and clinicians. And because what they know about medical humanities, according to these different faculty members, they're all very different, right? So I'm trying really to find a consensus, kind of overlapping area among among staff, right? And there is also insufficient communication. Always communication is not enough among teachers who believe that medical humanities is important and how we should really teach it, right? And then so I kind of designed a few workshops I will introduce to you later. Right, next slide. Right, so this is just this is another thing, another challenge for us, like we medical historians, medical anthropologists, and medical sociologists. We always think that medical humanities, in medical humanities, we should teach critical theories. And by criticizing medicine itself, I mean, for medical students or paramedics, that they would really want to feel pride in, right? It's difficult for them to believe that, okay, medical science is a construct, right? How can it be a construct, right? So we have to deconstruct their world, and then, but how, right? And still maintaining their passion, their enthusiasm on the way of becoming a medical doctor or nurses, right? So it's challenging. And also, I think medical humanities is already a discipline that have been developed for the past almost 30 or 40 years, and people still debating about, should we be teaching medical humanities as an instrument, or should we train physicians, nurses, that for them to acquire certain quality, professionalism, right? That is important in this scholarship, right? So yeah, another challenge. Next slide. Oh yeah, this is well, I've done it, so we can skip it. So in my teaching, I always observe that we've got a lot of learning theories, and for medical humanities courses syllabus, we can only reach level 2 about reaction and learning, and how do we influence their behavior after learning medical humanities, right? This is still a problem. It's difficult to assess it, right? And so again, challenge, right? Now, next slide. Right. So this leads to what I'm going to brief to you, my approach in medical, illness narrative or medical narrative that I'm currently experimenting. Now, for example, like in medical schools, we teach students how to diagnose patients, right? Using, for example, like physical examination, laboratory examination, but actually we see always we can only see very cross-sectional pictures of diseases. But actually in medicine, nowadays, we're entering the age of chronic diseases. Patients, they suffer across time, and then we don't see the whole picture, right? So how do we really develop students' understanding about the whole so-called holistic understanding of diseases, and not only diseases, but all kinds of health conditions. They are not necessarily diseases. Then, next slide. Next, please. Yeah. So this is my theory. I'm still writing up the article. I think soon it will appear in a blog called Somastosphere, right? That is now edited by colleagues based at King's College London. Right. So these are my 4 theories about the clinical applications of narrative medicine. First, narratives. They construct the reality of suffering. Because in medical schools, even for the education of medical diagnosis, we can only introduce cross-sectional picture of diseases. Right? And second, it offers perspectives. Right? So what doctors, patients, families, spouses, they think about the conditions of the sufferer of the disease. They're all very different. And then and narratives also provide resourceful support. And for example, like women who suffered from massive bleeding after delivery, and a lot of them went into coma, and then when they woke up, they don't know what's going on. And then a lot of hospitals are now collecting narratives of these people, patients, and trying to let people who experience this kind of condition to listen to other people's stories, so they know about what's going on. And also it closes the gap between the need and intervention. This is quite important because sometimes, medical policy makers, they often believe that, okay, and for example, like we can raise an example of what dementia. Now, the world of medical science has been looking for a particular medicine in order to delay the deterioration of our cognitive function, our memory loss. But actually, we have really spent too much money without being able to find a solution. But now, for example, like medical anthropologists, they have kind of interviewed extensively among clinicians, scientists, caregivers, and find that actually we don't need to spend that much money. Public health support, improved public health approach is more important, right? So this is how narratives function in clinical medicine. Yeah, next. Right. Because I think I only have 4 or 5 minutes left, I think we can all skip these slides because these are materials are available in the books. Right. Okay. So narratives about explanatory model, about perspectivism. Okay, next. I just want to briefly introduce my 2 workshops currently I'm experimenting. Next. Yeah, next. Yeah, next. Right. Oh, no, forward. Right. Again, I know what this is talking. What this is talking about. This is the same, right? The same. Okay, next. I want to look at this. Yes, I'm using verbatim theater to train students how to understand what caregiving is all about. Right? So it's not only about in-depth interviews. I send students to interview real caregivers of different kinds. For example, like for caregivers of dementia patients, caregivers of very young patients, and then so they have to learn word by word what these people are saying, and then in the end they have to edit a play based on the transcript of their in-depth interviews, and then they have to learn what the conditions are all about, and then they have to transform the entire thing as a play. In the end, they have to act them out. Right? So this is a kind of a training using the theory of embodiment. so that they learn and they can really behave like a caregiver in the future. And this is what I'm currently trying. And next. Yeah, next. Right, this is we do drama analysis and then we, oh, sorry, yeah. That's fine, we skipped it. Oh, this, I can say it here. And this is the second workshop. This is what we're doing, right? Transcribing, verbatim editing. And then most importantly, we invite those caregivers we interviewed to watch the play. And you can see what the situation is like. It's full of laughs and tears. It's the cathartic effect that really move these caregivers. And right, okay, next slide. And then this is quite interesting. I think I published an article together with Ellen in the same special issue in the same journal, right? So this is about teaching medical students history, right? And so I introduced a workshop I conducted when I was teaching in Hong Kong. We use medical museums to teach history of medicine, but I think we've got to draw back. Students, they might learn that they might think that the development of modern history is linear, but actually this is not the situation. So when I relocated to Taiwan, I began to think about another approach about how to teach, for example, like the history of epidemics. Using COVID as an example, I want students to bring along their own artifacts, right? So next slide. And then, so this is a kind of a curation. It's no longer a top-down approach. It's a democratic one. We discuss why these artifacts are so important to individuals, right? And then, so through this, we also discuss important agenda in COVID, for example, like human rights. We discuss gender issue, right, etc., etc. And then in the end, they have to curate. They have to. This is the we teach them how to write a piece of description about their artifacts, an artifact, and then we curate together a online museum of COVID. Next slide. This is what they do. Right. And then next slide. Yeah. And I don't know if you can play the footage that is embedded in the slide. If no, then that's fine. I can send you the link so that you can watch it. That's fine. Yeah. And now, if you want to know what I've been doing, for the past 6 years in Hong Kong, there's a chapter of medical humanities in this book, Practical Guide for Medical Teachers. Right. So the entire chapter is about medical humanities. And then the website is all my work. I'll stop here. Thank you.
Okay, thank you. I also had to stop sharing my screen. Thanks, Harry, for your presentation. I was impressed by the care with which you are trying to make the difference or make your work valuable to the medical context, and that you are trying to really involve also the students and think about making workshops. I think that is something which you should on a certain moment in the future share with us too, and with the other groups, because we can be busy thinking about a lot of concepts and theories, but in fact, if you really are working with caregivers and with students, I think Jurgen and I are also experiencing this, then other questions come up and other walls that we are have, or that we have to climb, of course. So I think your experience in this area is very valuable. Yeah, are there any questions for now?
I was wondering, Harry, about the verbatim theater experiment. Could you say something more about it? Is it somehow is the goal, let's say, similar to the I'm not sure whether you're familiar with it, probably yes, with the parallel chart exercise that Rita Sharon developed, in the sense of trying to get the, let's say, caregivers to try to not only take the perspective of the patient, but also really to experience or to embody that experience. It's more or less the same goal, but a different method.
Yeah, you're absolutely right. I think parallel chart, the difference between this and parallel chart exercises is just the style. I mean, for my workshop, it's really we want students to embody what they listen to, and then so that they copy not only word by word the verbatim, but also all the emotion, all the pulses, all the tears, laughters, right? And yeah, and we actually asked professional actors to train students what's acting about. And this is also very important. I mean, in practicing medicine, this is also a form of acting. And they never learned that in medical school. Yeah, right. And it's not only about verbatim theater. This is documentary theater. That means on top of verbatim transcribing, it's that they have to research themselves. For example, like when we are exploring end-of-life care. And so they have to, for these young students, they have to familiarize themselves with all the decision makings, very difficult decision makings they face, the legal terms, not professional and also legal terms, right? That they would encounter in doing all these interviews.
It's interesting what you say about the acting. I was a couple of weeks ago, I was involved in a conversation with let's say 7 or even 8 years students who were already in a specialist program, and at one point the discussion was about, you know, empathy and stuff like that, and I asked them at one point, I made the same comparison that you made about, let's say, acting to be a good doctor, and they were shocked. They were looking at me and saying, "What on earth are you thinking? What on earth are you saying?" So it would be interesting to hear your perspective on that. It's very interesting. Thank you.
Harry, that's fascinating, because I've had the same experience in my medical school. We do not teach any form of performance, but you know, they're performing a role.
That's right.
Yeah, that's a very, very strange idea to my colleagues. Do you, in your medical system, do you have a simulation center where you have role plays? So you do OSCEs, you have the OSCEs, okay. And that's a form of drama. Our OSCE patients are actually trained actors. So as you know, they often come from the theater profession, but I don't know why that's such a strange idea to my medical colleagues, that, you know, it's a performance. You know, it involves rhetoric, persuasion. You have to persuade patients. There's a lot of skills involved which we can learn from theater. So.
Yeah, it's quite interesting that I am going to take this this kind of, if I call it a pedagogical tool, I'm taking it out of the campus. Now I'm training people in the community really to explore different kinds of caregiving. Right? So I kind of collaborate with the literature museum, right? Yeah. And then so what they are interested in is theater production. What I'm interested is to really to teach people, ordinary people, what caregiving is all about, and through literature, drama writing, and most importantly, I think the most interesting part is that hang on, it's slipped my mind, right? I come back to this later.
Maybe we could first let Divya ask her question.
Yeah.
Oh, you are still muted, Divya.
Okay.
Yeah.
Thank you both, Alan and Harry. I had a question about language in the interfaces and the workshops that you've conducted. And of course, I can sense that, Alan, you know Arabic and can engage both textually and with people in the language. But in particular, I'm curious to know of any multilingual, perhaps having to do with immigration, multilingual scenarios. And as you can imagine, this is an important question for psychoanalysis, not just because it's the talking cure, but because of the way language, after Lacan was placed at the center of the theorization.
Yeah.
I would say just briefly, that is a huge issue in Qatar because my institution, the language of instruction is in English, and our patient populations are Arabic speaking, but also we have a lot of immigrants from Asia, East Asia, so a lot of people from Pakistan, India, and that's only been recently addressed. We were actually the first institution to institute a translation program. So it's a huge issue that's really not been dealt with. Language, culture, religion, and how that impacts the clinical experience. And again, I think our institution is the first one to really to bring this up, that this is a serious consideration in clinical care. So it's an ongoing process of negotiation.
Yeah.
Okay.
And thanks, Divya, for the question. I mean, when I was teaching in Hong Kong, English was the official language in education. But when it comes to, for example, like we invite caregivers or actually other chronic disease sufferers to really speak to students, we need to use Cantonese because this is a very intimate experience. They won't be, if it is still conducted in English, there is I think there's a hurdle, right? Not only intellectual, but also emotional hurdle there, right? And in Taiwan, the official teaching language is Mandarin. But when it comes to these narratives, Taiwan is a multi-ethnic society. Students need to get familiarized themselves with different languages, dialects, I mean.
Okay.
Thanks, Divya. And Anna Maria also has a question. Please go ahead.
It is really not a question. I have to leave to work now. I have to get there by 8:30, but I want to thank you all. And I'm very pleased to be here because we are dealing here with a question in the medical world and also in the academic world that deals with bioethics in Chile. That is a very basic question that I could see in Professor Wu's presentation about what is humanities. Is it something that doctors can teach, or is it from anthropologists? Is it something that we have to ask for social sciences, or is it something that we medicals can teach? Is it something that deals with art? Is it getting poetry or theater? And we are also dealing with the sense that in the medical and sanitary world here in my country, there is a whole wave of a lack of confidence in our professions, in the way that we are practicing it. There is like a huge gap between patients and citizens and us, and we are dealing with all these laws that come from a very deep distance between what people would demand from us and what we are actually giving them, or the way in which we are giving them. So we are asking the question about how does people is seeing us, after the pandemic, in which they were so thankful and we were like heroes, which I also would like to problematize, because we were doing our job the best that we can do, but we are not heroes. Heroes were the patients that had to face that in such an adverse situations and everything. But a couple of days ago, our dean visited our department, and he said, "Well, you are called bioethics and humanities. Why don't we skip the word humanities? We could take it off." And we suddenly were so annoyed. No, we want to we want to grab that world, you know. So give us some time, and we will, and we also almost like grab to the word humanities. And so we said we must define this. So we must present to the dean why it is important that we are still called bioethics and humanities. So I thank you for the space. I have really, since 6 in the morning to 8, I have had like this big trip. So I am very uplifted by this conversation, and I want to thank you all.
You too.
Yeah. Thank you, Anna Maria. Maybe it's also good at this point to mention that the first webinar, which is also recorded, will be uploaded on the website too, so you can also become inspired there, hopefully, to address your really crucial question.
Yes, and send your dean to our website. Tell him or her to have a look at it.
Yeah.
I must send him. Yes. Have a nice day. Goodbye.
Thanks
Thank you
for
very
being there.
much.
Thank you.
you.
Thank you.
So if there are no further questions, I think we can also close this session. Apart from your final last famous words, Jürgen.
No, it was very good to hear all of this. There's a lot of it's clear that there are a lot of things that are beginning to overlap. So I really look forward to continuing all sorts of conversations about teaching, about research, and about outreach. It was wonderful to hear all of you, and I'm so glad. I mean, from the bottom of my heart, I'm so glad that you're all part of this network in progress. So it's really going to be
Thank you for
an
providing the
amazing next
platform.
one. Yeah, no, thank you.
Yeah.
And see you soon, all of you.
Thank
Okay.
you.
See you.
Thank you. Bye-bye.
See you soon. Bye.
Bye.
Bye, everyone.